My talk is the effect of bariatric surgery in the era of nutrient-stimulating hormones. That is a new terminology which is being recently introduced. Even I got to know only about a week back. So the question is whether these new drugs will be more effective for weight loss compared to metabolic bariatric surgery. I think it is opposite. That is what I believe, and I tried to review the same on the Google search by AI, and the same question when it was asked, and the answer was that no, anti-obesity medications are not expected to replace bariatric surgery, and there are multiple such options. And this is an article which is published by American Association for Surgery for Metabolic and Bariatric Surgery, ASMBS, and they also said the same, that bariatric surgery is more effective and durable compared to the newer medications and lifestyle modifications. There was a article discussion on the same topic in European Association Study for Diabetes in 2024 at annual meeting and in Rome, wherein two speakers, one was an endocrinologist and second was a bariatric surgeon, Rubino and LJ Aron. So Aron topic was whether it will replace the bariatric surgery, and he was saying that trend could be due to obesity will get treated at early stage, even at the BMI of 25, 27. So, and only 10% change is required to make them normal. If someone doesn't respond to one drug, there will be multiple drugs available to replace these medications. Though he also added the people will be referred for surgery, but possibly only after they have not responded to medical treatment. And at the same time, he also said in the United States, it is much cheaper to have surgery, and I bet the insurance companies are going to make people have surgery before even they can get the medications, because in USA, insurance companies decide everything, the treatment part. So it is a major impact there. That is how in the BMI bracket in America is also decided by insurance companies. Once you reduce the BMI from say 35 to 32, the number of people will increase significantly. So there is a recent report from Morgan Stanley suggests that global market for newer medications will increase by 15-fold over the next 5 years as their benefit expand beyond weight loss, and as much as 9% of the US population will be taking these medications by 2035. Professor Rubino from King's College said, because these drugs are available to treat obesity, none of them are curative, and if they are stopped, the weight will come back. And more interestingly, he said the efficacy of drug which is measured in weeks and months, whereas the efficacy of surgery is measured in decades of durability. Like we have more than 6 decades of bariatric surgery which is being done, though newer medications are in last almost 2 decades. In case of bariatric surgery, it is 10 to 20 years, and that is why the bariatric surgery will remain an option to treat. This was published in Medscape also. So, in obesity pharmacotherapy, it was started almost 6 decades ago. Currently, 6 drugs are FDA approved for weight loss for long term, of which one is a device which works like a medication, 2 drugs for short-term use, and most of results are from studies about primary use, and data regarding use after surgery are still evolving. So these are the medications which are available. So this Gelesis is the one which is a super absorbent hydrogel particle, which is cellulose particles which will increase in size and give fullness. So though it is a device, it's used as a medication. So if you look at the comparison of all these drugs, diet, exercise, all medications which are available with the bariatric surgery, you can see the difference is significantly high. The bariatric surgery patients will lose more weight compared to the drugs. And here even in fact they compared it with even the tirzepatide of 15 mg. So still the difference is significantly high. These are the different medications which are being used. So drugs which are being brought to in market in near future are like GLP-1 plus amylin agonist, CagriSema from Novo. I think the trial is completed, but I don't think the results are as promising as tirzepatide. So They have not yet introduced it. GLP-1 agonist and GIP antagonist, that is AMG 133. GLP-1 agonist and glucagon agonist, that is pemvidutide and survodutide, and GLP-1 agonist and glucagon antagonist, and active receptor and agonist like bimagrumab. So I think bimagrumab is having a muscle preserving option. Why muscles are important? Because in all these medications, the muscle loss is a major concern. So this is a publication in Lancet Diabetes and Endocrine in 2024, wherein GLP-1 receptor agonist uses leads to short-term weight loss but substantial muscle loss. The total body weight loss is 25 to 39% over 36 to 72 weeks. Decline in muscle mass is far more than age-related muscle loss, that is usually a 0.8% per year after age of 40, and almost 8% per decade from 40 to 70 years of age. Why we need muscle? Because we can't afford to lose them. Muscles are the reservoir for amino acids, including those involved in responding to stress, trauma, and infection. They are required to have synthesis and storage of glutamine, involved in nitrogen transport and immune function, and they required to maintain the normoglycemia, to maintain a glucose homeostasis. So sudden loss of skeletal muscle mass is worrisome, and that is a thing we should think about whenever we are prescribing anti-obesity medication. We should measure muscle mass and during the treatment and maintain it as much as possible. So the newer medications which are being prescribed, GLP medications which are prescribed, are usually not being taken permanently. And most of these people, at the end of 1 year, only 32% people are still on medications, and at 2 years, only 15% people are on medication. Means most of them will stop medications, and once they stop medication, they will regain weight, and that is only fat regain and not the muscle regain. Similarly, there was a timeline supply crisis which happened in America. In 2021, they approved SEMA for the weight loss. 2023, they stopped semaglutide for weight loss. Similarly, in 2023, the FDA approved tirzepatide for weight loss, and insurance companies, they don't even pay for tirzepatide for weight loss in America because they can't afford to pay so much. So similarly, the weight loss with medication is about 20-25% while being taken permanently, and if surgery, it is 30 to 35% in the long term. Similarly, diabetic medications, the reduction of HbA1c by 2.2% is rarity with this medication. In surgery, it is always achieved in about 60 to 70% of people on the long run. Metabolic surgery with medications, if you look at the different adverse events, medication reduces the adverse event in liver events about 22% compared to surgery, which is about 88%. Similarly, adverse event for the cardiovascular, medicine reduces about 20 to 26%, and surgery reduces about 50%. And mortality, we don't know about medications, but surgery reduces the mortality about 50 to 70%. So if you look at this article by Cumming, there is all-cause mortality is reduced compared to normal population with metabolic surgery is significantly high. These are number of bariatric surgery which are being shown in America, which are not reduced so much except in year 2020. I think it was a COVID era. That is only year which they have reduced the number. Otherwise, the numbers has not reduced significantly. These are few articles showing the effect of GLP-1 on bariatric metabolic surgery, which was published in different journals. And this is a review article which is published in Obesity Surgery Journal in 2023, wherein they reviewed the GLP-1 receptors agonist in obesity management, and they discussed the complementary role of GLP-1 drugs and bariatric surgery, and they highlighted that synergy of postoperative patients struggling with weight regain will have a better outcome when we are using these drugs, and they identified the key research gap in long-term efficacy and adherence to these drugs. This is another systemic review which highlighted benefit of GLP-1 for the weight loss, and it summarizes both pre and post-operative use of these medications and discusses potential for reducing long-term complications post-operatively, and it reinforces the importance of individualized care strategy in these patients. This is our article which is published wherein we advocated this to be used along with metabolic and bariatric surgery, and this is a recommendation from India where I'm also a part of this as an author. This is our JAMA's recent post wherein they have compared bariatric surgery with the GLP-1 receptor agonist, and they also found the effect of bariatric surgery significantly more high than the GLP-1. So more importantly, are we going to use these drugs forever? We can't. So this is a new surgery which I have designed wherein we do sleeve gastrectomy joining the jejunum here. So we have a route which is available for food to go through this route also and this route also. So this is a combination of sleeve plus Roux-en-Y wherein we can preserve the stomach physiology, we can maintain the normal anatomical passage. It reduces the hypoglycemia, which is more common after gastric bypass like dumping syndrome, which can be reduced. And these are few results of surgery. If you look at this lady who can dance after surgery after 6 hours, and the same girl is dancing after 1 year. So these results are only possible with surgery, and with this I complete my talk. And so this is a conclusion slide. GLP-1 drugs are transformative obesity treatment, but do not replace bariatric surgery. Surgery remains gold standard, though nowadays the gold standard word should not be used in our medical term. There is nothing gold standard in surgery, at least. And the GLP-1 drugs are effective in preoperative and postoperative management of weight, and integrated care models required combining pharmacotherapy with surgery are being used to have a better outcome, and future research will be focused on long-term comparative efficacy and patient selection in these patients. So similarly, if cancer we can prescribe chemotherapy, why can't we prescribe medicine after bariatric surgery? So we should treat obesity just like a long-term disease like cancer, wherein the radiotherapy, chemotherapy, everything is possible. So I think the obesity needs to manage like cancer as well. And with this, I